all of you. On behalf of Relisys Medical Device Limited, I want to welcome you all in this evening and a heartfelt thanks to all the faculties as well as the attendees who have taken out their valuable time from their busy schedule. Let me take you through the journey of Relisys with the inspired vision by Dr. Abdul Kalam to make medical care affordable. The company became an independent entity under the name of Relisys Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market high quality medical devices in cardiovascular range at most affordable price, thus helping needy patients in India and across the globe. Backed by technocrats and medical specialists, the name Relisys emerged from reliable system which ensure performance, efficacy, and safety to the patient. The strategic path adopted by the company was to use innovation, cutting-edge technology, besides scale of production to achieve product and pricing advantage over competition. And today, we own a clean and green state-of-the-art facility built in more than 12 acres of land, 160,000 square feet build-up area, clean room of more than 60,000 square feet of 10K, HVAC building management system, built as per the US FDA norms. Entire facility is certified as ISO 13485, DSAR approved and R&D laboratory, fully integrated end-to-end solution for manufacturing stent as well as catheter. And today we are one of the largest stent manufacturer in the world. This is a small glance into our factory. And with the vision of expansion, in 2018, Relisys has acquired Multimedics LLP, a C-certified company, as a part of the expansion plan. This is our product range, starting from bare metal stent, cobalt chromium C, drug-eluting stent, Premier Plus, Pristine Plus, balloon catheter in the form of Pearl AC and NC, angiographic diagnostic catheter, Anand. We do have CE marked as Ensure Ace, guiding catheter, Amber, guide extension catheter, guide Zila, sizing catheter, Quartz, pulmonary artery catheter, Ripacath, transcatheter heart valve, which is tricuspid, for tricuspid valve, that is trig valve, transcatheter aortic valve, Vienna, Expanse, which is an expandable introducer sheath, Relica as a microcatheter. We do have peripheral vascular product range as well in the form of Coral, Advert B, Engross, Engross HP, Perinity, Peripac Ace. And this is a new product range in our basket. We have recently launched abdominal aortic stent graft system, which is Metagraft AAA, thoracic stent graft system, Metagraft TAA, cutting balloon, Pearl CB, as well as coronary DCB, which is Pearl DCB. So this is our new product pipeline, which is going to live very soon. So we are going to launch intravascular lithotripsy, steerable microcatheter, central venous catheter, hemodialysis catheter, covered sheath, transcatheter valve, as well as CTO recanalization devices. And today we present more than 55 countries across the globe. With this, let me welcome you all to the inaugural episode of CUT COAT Chronicles, a webinar series which is dedicated to advancing precision in the coronary intervention, and where we are going to witness the evidence-based discussion on integrated CUT COAT strategy that transforming the outcome of coronary intervention. And let me take this opportunity to welcome the facilitator of this evening, none other than Dr. Dilip Kumar. Dr. Dilip Kumar is a director of Cardiac Cathlab of Manipal Hospital, EM Bypass, Kolkata. Welcome, sir, and once again, thank you very much for accepting this invitation and your presence. So this session is now over to you, sir. And now I'm stopping the presentation here. It is all yours now. Thank you so much.
So, thank you so much, Madhumita, and it's indeed a pleasure to be there in your inaugural episode of Cut and Coat Chronicles. And it's so heartening to see so much of Indian companies doing so well, and we have whole lot of products still in pipeline, and this is going to be revolutionizing the way interventional cardiology has been practicing in India for last 1 or 2 decades. So with this note, let me go ahead with the agenda of the program. So we have basically three presentations, and one by Dr. Prashant Pawar. He's senior interventional cardiologist, Fortis Hiranandani Hospital, Mumbai. Then we have second presentation by Dr. Chirag Parikh. He is also from Mumbai, from SR Mehta Hospital. And then we have finally a presentation by Dr. Stalin Roy, who is a senior cardiologist in Kaveri Hospital, Chennai. So we have been witnessing the transformative nature of interventional cardiology, which has been, practicing off late for last 5 years, and we are, going away from stents in many of the lesions where we can definitely go without putting a metallic jacket. And this concept is getting and gaining more and more prominence. We have got a lot of evidences pouring in, and believe me, all trials, all meta-analysis, they do show some benefits, numerical benefits in DCB arm. There is only one trial, that was cage-free trial, which showed some kind of results which was otherwise. But there is a lot of things to discuss about cage-free. Cage-free is a Chinese trial where the device itself was not evaluated properly. So we don't know the device, and it is not much in world market. There's device based only in China, and they did the study, and then every study, every talk on DCB, we throw questions on a cage-free trial, which I don't think it's worthwhile to discuss. Besides that, besides this trial, all meta-analysis, all trials, they have shown DCB as non-inferiority, non-inferior one. Rather, numerically they are better. So with this pretext, let's go with the first presentation. So I think Dr. Prashant will be sharing a screen, presenting a case on DCB. Then we'll all discuss, about that case.
Am I audible?
Yeah, Prashant, we can hear you.
Am I audible, sir?
We can hear you, Dr. Prashant, and we can see your presentation. You can go in PowerPoint, you know, slideshow view.
Yeah.
We
Good
can.
evening, all of you. I welcome you all for today's CME, the webinar sponsored by Relicis. Now, my topic given is why DCB in coronary intervention when we have excellent stents available. Now, we have seen through all the papers, right from the BBC One, which showed one stent is better than two. EBC2 showed one stent may be better than two, and the EBC main showed one stent is better than two. So if one stent is better than two stents, then is no stent better than one stent? So that's how this concept of DCB started. We all know the fate of metallic implants in the coronary arteries. If we see this long-term data from Madhavan et al. Showed the blue color graph is of bare metal stent, the red one is first generation DS, and the last black one is the second generation DS. So after 12 months of implantation, we can see there are high chances of event rate, almost to a tune of 17.9% in the bare metal. Even with the drug eluting stent second generation, still we had almost 5.1%. And if we see the late stent related events, they occur between 1 to 5 years after the PCI, and almost every year there is a 2% increase in the failure rate without any plateau. So what we have understood that definitely stents do create a problem in the long run, and hence how to improve the long-term outcome after PCI. Even the third international DCB consensus, it came out with a beautiful data where we have something called as an acceptable angiographic result. So suppose we have no flow limiting dissections, the residual stenosis is below 30%, and your FFR is more than 0.8. So the imaging wise, we have below 30%, physiology FFR more than 0.8, we can get away without stenting by drug coated balloon. Now my colleagues, they'll be talking about the lesion preparation. Dr. Chirag is going ahead with the lesion preparation later, where we have the scoring balloons, cutting balloons, non-compliant, So all these things will be coming in the later lecture. Now even ESC guidelines recommend that earlier it was a DS 1A recommendation, but even DEB have approved as a class 1A recommendation for the ISRs of both bare metal or the drug-eluting stents. So DS are safe once we do the stenting IVAS guided or OCT guided, but still the issues of ISR do occur. The drug-coated balloon, they fail to demonstrate the non-inferiority, what earlier speaker spoke about in the cage-free trial, but it was not inferior to DS in the small vessels which came from the basket trial in diabetic mellitus, and in the de novo lesions in solution de novo study. The other option remains, why not to combine DS with DCB for distal small vessel disease, and that again is in a is the trials are going on. We have certain data available which I'll be speaking about. So which patients and which lesions to go ahead with the DCBs? So one is the lesion characteristics, the ISRs, small vessels, bifurcations, long disease or diffuse disease, certain patient characteristics like diabetes mellitus, even in acute coronary syndromes, and high bleeding risk patients. So in diabetes, problem occurs, there is more of inflammation, there is more of thrombosis, there is more of endothelial dysfunction, and all of these are known to cause either thrombosis or late ISRs. So this trial of Bello trial, which in diabetes mellitus small vessel disease, it compared drug-coated balloon versus DS. If you see the stents were Taxus stents and the balloon use was sequent please, in which it was found that in diabetic patients, the DCB, they did better as compared to the stents. So coming to the baskets small 2 trial, where in diabetes mellitus, where the vessel size was below 3 mm, where this compared the drug-coated balloon with drug-eluting stents, which was most of the time it was Zion stent, and in few cases there was a Taxus stent. And this also showed that in diabetes patient, if you see the red graph in the diabetic patients with DS, and in the diabetic patient with drug-coated balloon, the yellow graph, there was a huge difference after 12 to 18 months after implantation, there was a huge difference in the outcomes. So diabetic patients, they do better, especially small vessel disease, they do better with the drug-coated balloon as compared to the caging by the stent. Even the meta-analysis, which showed drug-coated balloon versus stent, mortality rate was significantly lower in the DCB arm, as well as the target lesion revascularization was significantly better in the DCB arm as compared to the drug-eluting stents. The next concept, what I was speaking about, was this hybrid strategy, where in the big vessels, to go ahead with the stent, and in the branches, and in the small vessels, to go ahead with the drug-coated balloon. So what was found in the diabetes mellitus, patients who opted for this hybrid approach, where stents were used almost to a tune of 33 plus 66% lesions were undergone a drug-coated balloon, they did better as compared to the stents only arm. So the hybrid approach did better. So the take-home message was the metallic implants in coronary arteries, they are associated with a high event rate, specifically in the high-risk patients, diabetic patients, where the event rates are high. In diabetes mellitus, the DCB arm, they have a potential limited results of DS due to their unique mode of action. The available data show there is a clear benefit of DCB in the diabetes patient when compared with the DS. Although large-scale randomized control trials are missing. So if DCB would be used more often in PCIs, maybe we'll get a good amount of data even in the diabetes. Now coming to the stent-related events. Now problem with the young population. If you see over a period of 12 to 24 months, almost 2% event rate per year occurs. and this will continue to go long. Now, we see so many young patients, 30, 35 age, they come with MIs and they are stented. So the vasomotion is affected and rate goes high. The other problem occurs in the STEMI, where there is a lot of thrombus. So because of thrombus, because the vessels are underfilled, we try to, sometimes everything is not image guided. So we try to undersize the stents. On top of that, there is a lot of inflammation present around. And once the stent is put, there is the impaired vasomotor function. So all leads to a malapposition and a delayed endothelization, which creates a problem in the long run. So if there is an absence of a permanent implant, so which will take care of the long-term DAPT, or in cases where there is a high bleeding risk, or they are intolerant or poor compliance, especially Indian populations where they don't comply, they don't do the regular follow-ups well, the DCB did better. Now coming something called as the optimal result after lesion preparation, where uh, what I told was a non-flow limiting dissection, so TIMI3 flow, residual disease below 30% and FFR above 0.75. This can be safely tackled with the DCB alone rather than the stents. Coming now, we have various technologies of DCBs, right from the molecules, paclitaxel, biolimus, sirolimus is available with us. Second, the techniques are different. The coatings are different. We have certain which are hydrophilic matrix, certain are are phospholipid based. Third are the nanoparticles and the glucose. We have certain available with us was the sequent please, which is more of a hydrophilic matrix. Magic test has more of a nanolute, and the solution which has more of a nanoparticles available. So all these drug coated balloons, they will have a different technology. The whole aim is to deliver the molecule, deliver the drug in the vessel, and to keep the action going on. So commercially different DCBs are available, but you can't compare one balloon with other. So because the interaction occurs among the dosage, formulations, the release kinetics, and the drug, both are different. So it's not a class effect. So DCB is not a class effect. Each balloon will act differently. Now coming, is there any alternative to DS? So yes, definitely there is the alternative needed, where in small vessels, in long lesions, high syntax scores, bifurcations, even CTO, now we have a good amount of data available, and in STEMI patients, definitely we have certain other options. Various different indications. One is ISR, where we have a class 1A recommendation. The data from PACOCAT, PEPCAT have proved that DCBs do better in ISRs, provided the lesion bed is prepared well by scoring or cutting balloons. Small vessel disease, Bellow trial, basket small, all had a positive outcomes. In antiplatelet risk, where they don't tolerate antiplatelets for 12 months, the debate trial showed DCBs did better. We have in bifurcations again, PEPCAT as well as BioLux trial, which was a positive trial, and the large vessel disease, where it was the cage-free one or solution was a positive trial for a large vessel trial. And in acute coronary syndrome, again, we have a good amount of data where DCBs do better as compared to DS. Now, coming to the instant restenosis, where earlier it was only a DS, where ESC 2018 the recommended DS as a class 1 indication, but now even a DCB is a class 1 indication. So what we can see, the difference in the graph, if you see from the Daedalus trial, the blue arm is the drug-coated balloon, and the red one is the DS, where we can see, though the efficacy endpoint was slightly better in this trial with the drug-eluting stent, but if you see the primary safety endpoints, the all-cause death, myocardial infarction, and the target lesion thrombosis was better with the drug-coated balloons. Again, in the small vessel disease, the Andromeda trial showed the MACE as well as the target lesion failures. They were better with drug-coated balloon as compared to DS for the small vessel disease. A large amount of rumors had come with the toxicity of this paclitaxel from the DCBs in peripheral arterial disease and all. But all the datas have come up where the paclitaxel may remain elevated in the tissue for first 24 hours, but later on, after 24 hours, there is a acceptable amount of drug available. There is no toxicity because of paclitaxel in the DCBs. Coming to the gold standard, now all the data has proved that paclitaxel coated balloon, those are like a gold standard arm. So every balloon comes which we compare with this paclitaxel coated balloon. So right from the Transform 1 trial, which compared the Magic Touch balloon with the paclitaxel balloon, which was unfortunately a negative trial in the Transform. And then the other trial came where which compared the biolimus. This was the reform study, which compared the biolimus with the paclitaxel. Again, it was a negative arm. So you can't compare one balloon with other. Definitely, every balloon has a different, unique way of action, and the molecules differ. Coming to in ISR, the paclitaxel versus sirolimus, where this was a positive trial where it showed it was a the sirolimus coated balloon were non-inferior, in cases of ISR. Coming to again one more positive trial which compared in de novo lesions, sirolimus coated balloon versus paclitaxel. Again, it showed that in sirolimus, the late lumen loss was almost same as in the paclitaxel. So again, it was a non-inferior as compared to the paclitaxel. Coming to the young patients, again, there is a high unmet needs in coronary artery disease, especially for younger patients. If you see over 10 years post stenting, 1 out of 2 patients will have a MACE. So imagine our patients, what we are stenting at the age of 30, 35. After 10 years, it's not a big time actually. 30 to 40 years, not a big time. So almost 50% will have some amount of MACE rate. So in those cases, the choice of thing will be to get away with something which won't cause problems in the future, to get away from the caging. So if you see this trial where it compared the sirolimus and the zotarilumus stent. So 2 stents were tested, the older one as well as the zotarilumus arm, and which showed almost same event rate in both sirolimus stent as well as zotarilumus stent. So definitely stents won't make any difference if you take this stent or that stent. I feel what makes difference is to avoid the caging. On top of that, if you have a comorbidities like diabetes, then it will make the situation more worse. The MACE and the plaque disease progression rates, they almost double in diabetic patients. So if you see there is a diabetes, almost the MACE rates are increased by 2 years, almost 2 times at the age of 12 months. Even the plaque disease progression is almost twice high in diabetic patients. So definitely in diabetic patients with high comorbidities, the DCB do better. Coming to in bifurcation, so how does DCB fit into bifurcation PCI? So one, we should know whether is it a main branch DS case or what we are planning to do, whether it will be a planning main branch stenting and just POBA or a DCB to the side branch. So we have all these 5 options available, out of which the first 2 options are for stents, that is provisional main branch stenting, and just to leave out or to bail out the side branch if the flow reduces. The second is a planned hybrid where you prepare both and do a DCB to the side branch first and the DES in the main branch. And the less rest free down, those are dedicatedly for drug coated balloon. That one option is simple, that is a short side branch is there. You prepare the lesion and drug coated balloon to the main branch and don't do anything for the side branch. The second option, if you have a Medina 0001 side branch only, so you lesion prepare and use a drug coated balloon to the side branch and no main branch treatment. The last option, which the recent was presented in the ESC, was this leave nothing behind, where you have 2 lesions, prepare main branch, prepare side branch, and sequentially use drug coated balloon in both side branch as well as main branch also. So no case. So this are the 3 simple or you have leave nothing behind options. So this new concept of bio-PCI has come, where B is be good, avoid less metal, so use less metal. Second, I is for intervention without permanent foreign bodies. And third is optimal medical therapy and healthy lifestyle, where control of your cholesterol levels are high, seeing the lipoprotein A, now this inclisiran has come up. So this is a new concept of bio-PCI which has come up, which favors drug-coated balloon as compared to the stents. What I told in bifurcation DCP, the advantage of DCP is that you don't have this wire wrap, you don't have a wire jail, no pot required, no crossing those proximal strut or distal strut, nothing is required, no deforming and reforming the stents, unnecessarily kiss are not required. And but the only advantage, the thing needed is you should prepare the lesion well. By the next topic, my colleague will be taking care, where the lesion should be prepared well. Coming to the CTOs, why it came is because we all have seen that vessels are underfilled. They are we undersize the vessels, and it has been seen that the distal vessel diameter, it increases over time, over 9 to 12 months of follow-up. So if you put the stents of those size of 2.5 or 2.25 undersized vessel, later on it causes ISR. So DCBs in CTOs have come up with a big way. Coming to the complex PCI, again, we all have seen that complex PCI has a high event rate, considering the TLF rates, the cardiac deaths. So in all these cases, DCB does better as compared to the stents. Now, fate of stents, I had spoken earlier also. Now coming to this Picolet trial, which was for small vessel disease, where again, this in this trial, it has been seen that in small vessel disease, the drug-coated balloons, they did better as compared to the drug-eluting stents. In the large vessel, we have a good amount of data where we propose the drug-coated balloon, including with a hybrid approach when needed, where you have a triple vessel disease or you have a bifurcation, including the left main, or your lesion length is more than 4 centimeter, or you have ostial lesion or total occlusion. In those cases, certain groups have preferred this hybrid approach, where
Prashant,
a hybrid approach of DCP and DS, they do better. So
Prashant, if we can.
lesions treated with metal DS, they have a sustained events during follow-up. What evidence we have is definitely replacing a metal with devices like drug-coated balloon, they do better. Uh, Again, Lancet 2024, a beautiful paper where in small vessel disease, there is no reason not to use a DCB, you know. So a beautiful paper which has been analyzed from this cage-free trial. And again, in non-small vessel disease, again, use DCBs whenever possible. And otherwise, if you have all these three criteria not match of FFR or low limiting dissections, or the lesion still more than 30%, then the DS are required. So in complex PCI, we all have seen that DCBs do better, especially in older age groups, patients who have multiple comorbidities like chronic kidney disease, patients who have bifurcation lesions, multi-vessel disease, proximal LAD involvement, they do better with the DCBs as compared to the DS. Coming to the high bleeding risk, we have seen that patients do not tolerate the drug-coated balloons, do not tolerate the dual antiplatelet agents for a prolonged time. So we see so many older age group patients who may have planned surgeries, or they have underlying GI problems or underlying issues with the brain bleeds and all, or who have active cancers. In those cases, we can't stop the dual antiplatelets within 4 weeks, or we can't stop all the antiplatelet within 3 to 6 months. So this debate trial showed in this high bleeding risk patients, the DCBs did better. Recently, I operated one patient where he had a uro cancer. He was with this Foley's catheter for his CA prostate, and which has spread to the bladder. And he had active hematuria at home. And he came with the inferior wall MI with a AV block. And PDL, there was a lesion. Unfortunately, we couldn't give aspirin, we couldn't give heparin. We thought, why not to take him in the cath lab with 1,000 heparin. We just did angio, where we saw the PDA, there was a lesion. So what we did is we wired it, we prepared the bed well, and with a drug-coated balloon, we inflated well for 2 minutes, and then there was a good result later on. Patient was sent home on a single antiplatelet, which was started after 24 hours. His hematuria was still there. He went home after 7 days, came back again. He's on single antiplatelet now and doing well, So, and that AV block also subsided after that lesion preparation. So, in such high bleeding risk cases, definitely DCBs do better. The other concept of this late lumen enlargement after DCB therapy is there, where we have seen that it is important in de novo lesions. It is seen more frequent in the paclitaxel DCBs rather than the sirolimus DCBs. The cytotoxicity is not that much with the paclitaxel, and it is more frequent if you have a dissections. If you have what what everyone calls as a beautiful dissections. So people initially used to get afraid of seeing the dissection, why not to stent it and all. But we consider as a beautiful dissections which are required for the drug coated balloon action, and the late lumen enlargement is better in those beautiful dissections, and they have a better angiographic and clinical outcomes after this. So the take home message is in ISRs, unnecessarily making a double metal layer is of no use. No distortion of the original vessel anatomy. Avoid chronic inflammation due to absence of polymers and better endothelization. So because of which we can reduce the DAPT therapy. So DCBs have been tested in the various indications such as ISR, small vessel disease, high bleeding risk, bifurcation, as well as ACS and CTOs also now. There is a large amount of different DCB systems on the market with a different concepts, formulation, drugs, and drug dosage. There is no class effect which can be assumed in DCB. Every DCB must prove its own efficacy and safety. Paclitaxel balloon, which has been used over 20 years, we consider as a gold standard. In more than 2/3 of all available data is also available. And we compare next balloons with paclitaxel. So, one, no stent is always better. Second, more the size of the length, more the chances of TLRs and the patients coming back with the mace. And small the stents, more are the chances again of failures. So smaller the stents, larger the stents, large amount of stents, they are going to create a trouble. So DCBs do better in such cases. We require beautiful dissections, what Dr. Chirag will be speaking about it in the coming lecture. I think, thank you all of you.
Thank you, Prashant. I think it was a very extensive review of the literature, and also you highlighted the different scenarios where DCBs are, preferred, and where the scope of DCBs are there. So there is no doubt ISRs are number one choice, where the DCBs are number one choice, and then we have small vessel, bifurcation, CS, HBR patients. So Dr. Hazra is there. We will have one comment and some his insights on your presentation, and then we will move on to the next presentation.
Right, he has already spoken extensively on drug-coated balloon. Chirag is waiting. I think just to correct Prashant, leave nothing behind is actually a misnomer now. Leave nothing behind means a POVA area. Then we came down to leave everything behind with a cipher like polymer and drug. Then we came down to a beautiful drug. Then leave the best thing behind, the best drug behind. So if to leave behind a best drug, it could be paclitaxel, it could be sirolimus, it could be other limas, but you have to prepare the bed. I think with this, we'll move on to Dr. Parekh, Chirag Parekh. He can highlight whether my statement of leaving nothing behind, leaving everything behind, leaving the best behind, or something else. Over to you, Chirag.
So by the time Chirag is setting up, so Prashant, if there is a kind of a cath lab where there is no imaging facility, so do you feel any challenge in using DCBs there with present guidelines, present practice? What is your opinion and insights on that?
Guideline will always comment about those imagings, but in our resource limited settings, and sometimes the facilities are not available or because of the cost factor, I think no harm in using DCBs. I think we all have seen the dissections before imaging came. if we prepare the bed well, if we see angioscopically certain findings where we can leave those behind, I don't think so there is any contraindication of not using DCBs.
Absolutely. So, so at this moment, present guidelines that it doesn't depend on your imaging when you are going going for a DCB or a stent. It's all your visual angiographic picture, the grade 1 to grade 2 dissections, and the flow which you are getting. If you're able to do FFR is good enough, but imaging doesn't come into the algorithm to decide whether DCB should be done or not. So any center anywhere depending on angiographic findings, you can well go ahead with DCBs. Perfect. So we can move on to Dr. Chirag's presentation.
Thank you, sir. Good evening to everybody for the patient hearing. Thank you, Dr. Prashant. I think he has covered beautifully most of the literature on DCB. So topic assigned to me today is managing ISR, cut, coat, or both. And I think I'll just stick to some cases and then we can have a discussion on what we see on a day-to-day basis. So is my slide visible?
Yes, yes. Go ahead.
So we all know that instant restenosis is the Achilles heel of modern day PCI. And the biggest drawback of stents is that they come back with the restenosis. And primarily, it is based on one of two mechanisms. Either there is a hyperplasia of the neointimal tissue or there is a neoatherosclerosis, which presents as a late ISR, and NIH is generally the early presentation. And multiple trials have been conducted which have evaluated both DES and DCB as a treatment option for ISR. And I think sir has highlighted the Dallas trial, and the multiple trials have been done which compared. And in the last guidelines published by the ESC in the management of chronic coronary syndrome in 2024, they have mentioned that DES is a class 1 indication and DCB is the class 2A. So actually it's not so simple, but to put a DES in all ISR cases. And there are multiple factors which actually influence what should be the treatment modality and what will impact the outcomes. So it depends on the lesion complexity, it depends on the size of the vessels, it depends on the mechanical factors also, like the stent under expansion, which are, in my experience, usually always present in early stent failures. In late stent failures, it may be a pure biological failure, but most of the times in early failure, there will be some mechanical component in addition to a biological component. And the presence of already prior multiple stent layers also influences our choice of therapy. So most of us are familiar with this old classification of ISR, but actually this is the one which is still most relevant in day-to-day clinical practice. And this is the Waxman classification, and it divides the ISR into 5 types. And type 1 is a mechanical failure of the stent, either due to stent under expansion, or type 1B is because of stent fracture. Type 2 is a biological failure, which is a neointimal hyperplasia, is a type 2A. Neoatherosclerosis non-calcified is a type 2B, and neoatherosclerosis calcified is a type 2C. And the mixed pattern, which is the most common, is a combination of the mechanical and the biological entity. Type 4 is a chronic total occlusion, and type 5 is more than 2 layers of stent. So most commonly what we see in practice is the type 3, which is a mixture of the combined mechanical and biological. And also commonly we see the type 1 and type 2. So this classification is predominantly based on imaging. And what this stresses again and highlights is the importance of imaging in all cases of stent failure and ISR. I think this is one of the class 1A indications for performing imaging in the Cathlab, and that is a stent failure. I think almost all stent failure cases should get an image-based PCI. So what are the advantages of DCB over a DES in a ISR? And the primary advantage is already that the patient has got a metallic layers inside his artery. And by implanting a DCB, we can just prevent these further metallic layers. It allows for a rapid and uniform transfer of the anti-proliferative drugs into the vessel wall. And there is no foreign body which actually remains within the vessel lumen. And this promotes a natural vascular healing and a positive remodeling. But most important step in the DCB is not the DCB. It is actually the optimal bed preparation. And the success of DCB angioplasty lies in the optimal bed preparation. Whichever trials have been performed and the outcomes of the trials, if it is an image guided or angiography guided, and if they have used additional tools other than just a routine balloon angioplasty, they have shown a superiority of the DCB over the DES. So the bed preparation is actually the key in both de novo lesions, but even more it is important in the ISR cases, where before putting the DCB, the bed preparation is absolutely mandatory. So what we must understand that DCB is not intended for balloon angioplasty. It's just a tool for delivering the drug. And we do not inflate the DCB to more than the optimal pressures of 7 to 8 atmospheres. And optimal lesion preparation is crucial before the DCB application to ensure that there is a successful delivery and there is an adequate luminal gain. And multiple tools are available for preparing this vessel bed. So this is a jack illustration where they have shown that before even thinking of the DCB, we have to do the optimal lesion preparation. And that can be done by multiple ways, either with a balloon-based technology or with a ablative technology or with a lithotripsy, or now we have ELCA also. So with this, we have to first prepare the bed. And only after that, if we have satisfactory result, which means that there is no flow limiting dissection and a residual stenosis is less than 30%, then only we should proceed with a DCB. If we do not have this acceptable result, then we should go for a DES or a biovascular scaffold. FFR also plays an important role in this. If we have a FFR of more than 0.75, only then we should go with a DCB. So again, this goes to highlight the importance of bed preparation before the DCB implantation. One of the tools which I have been tasked to discuss with today is the CUT. So the advantages of the cutting balloon especially in ISR cases. So cutting balloon is basically it's mounted with the carbon fiber blades, which actually cause cuts in the tissue. And this is one tool which we use very commonly in ISR cases because it gives certain benefits. So it generates a greater lumen at lower pressures. It increases the lesion compliance by it reduces the risk of plaque shift and reduces the risk of elastic recoil of the tissue. And also it provides a good anchorage, so it prevents the balloon slippage. So in compared to normal high pressure balloon, the cutting balloon offers certain advantages, especially in ISR. And how this balloon works is by the microsurgical atherotomes, which are mounted longitudinally along the balloon surface. And when the balloon is inflated, most of the force is concentrated on the edges of the blade. And this creates linear incision in the plaque like a surgical scalpel. And that is why this allows better penetration of the drug into the tissue and thereby better outcomes. So I will just like to discuss two of our complex ISR cases. So the first case is a 64-year-old male who is non-diabetic, hypertensive, who had an inferior wall MI and underwent a primary PCI to his RCA with a 3024 stent distally and a 3048 stent proximally. He now presented with new onset angina and STT depressions, and he's been compliant on his medications. And this is his angiography at the time of presentation. And we can see that the stent starts right from the ostium of the RCA, and there is multiple high-grade stenosis with reduced antegrade flow in his RCA with a subtotal occlusion. His left system was normal. So with this, we decided to go with the image-guided PCI of his RCA. So we took a RDC guide because of the ostial lesion and wired with a cyan blue extra support wire. Did a initial pre-dilatation with a 2O balloon and then a 3O non-compliant balloon. And after that, we performed the OCT. I think in stent failure cases, OCT has a clear advantage over IOS because we are able to classify the type of ISR, whether it is a NIH or it's a atherosclerosis. And here we can see that it's predominantly a homogeneous fibrolipidic sort of a tissue, which clearly represents a NIH rather than a neoatherosclerosis. There is no calcification at any point. But also one thing which we notice is that at the level of the IA stenosis, there is a significant stent under expansion. So the 3O stent had actually only expanded to 2.25, 2.5. And that is also, so it's a mixed type of ISR which we are seeing. And that is again what I'm trying to stress in these early stent failure cases. There will always be some component of a mechanical failure in addition to the biological failure. So with this, we are dealing with both stent under expansion and a neointimal hyperplasia. So most important thing before putting a DCB in this case is to prepare the bed well. So this is the summary of the OCT, which showed that it's a NIH with stent under expansion, and the strut to strut expansion was only 2.7 and 2.5. So we decided to first prepare the bed with a OPN NC balloon, which was a 3O balloon inflated up to 40 atmospheres. And after this, we followed it up with a 3.25 cutting balloon at 14 to 16 atmospheres. And proximally, actually the vessel was even bigger. So we did a 3.5 15 NC balloon in the proximal part. And after doing this extensive bed preparation with 5 balloons, then we do the repeat OCT run. So this is another thing that we are doing is we do the repeat OCT before the DCB implantation. And I would like to have the opinion of both our senior faculty here at what do they think. A lot of people say that you should not do OCT after the DCB implantation. So after this, when we had adequate lumens of more than 5.5 across the entire stretch of the vessel, and we can see that there are nice cuts with the cutting balloon inside the tissue, then we decided to implant 2 DCBs. So now we can see after this, we have got a significant luminal gain and we have got good dissection cuts because of the cutting balloon. And after this, we put a 3040 DCB distally and we put a 3.540 DCB proximally, both for 90 seconds at 7 atmospheres. And this was the final result. So this patient is on follow-up now for almost 18 months and he has no recurrence of events. They have kept his LDL to less than 55. He's on bempedoic acid with statin. So this was the first case, and this is the second case, which is a 17-year-old lady who's uncontrolled diabetic and uncontrolled dyslipidemia, who underwent a CABG with 2 grafts, Lima to LAD and vein graft to RC in 2021. In 2023, she again had angina and her RCA graft was occluded. So she underwent a PCI to the RCA with a 3028 DES. In 2024, she again developed angina and she had a distal edge ISR of the RCA stent. So she again underwent another PCI with a 2.75 18 DES at the distal edge. And this was not an image guided PCI. And now in 2025, she again presented with unstable angina. And this is her angiography. We can see that she had a tight calcific nodule in the mid LAD and another lesion after the diagonal branch. And her RCA, there is now another ISR which has developed, which is a focal 80% ISR in the mid part of the stents. And her Lima has also now become atretic. So now all our bypass grafts are occluded. The previously deployed stents have failed. And again, there is a calcific lesion in the LAD. So unfortunately, there are, this family was not willing now for, after so many procedures, we had a discussion for a redo CABG, but she was not willing for another surgery at this point. So this time we decided in the first stage to tackle the RCA ISR and then wait for a few months. And if the ISR is not recurring, then we will try to fix the LAD in the second stage. So we did a OCT imaging of the RCA. Unfortunately, because of the tight stenosis, we did not get a very great image. But if we can focus on this part here, we can see that there are two stent layers here. And actually what we found that the new stent, which was a 2.75 stent, is actually expanded only to 2.2. And this is, again, there is a NIH tissue here. And we can see that the stent under expansion and neointimal hyperplasia is what is causing the instant restenosis at the layer where the two stents are overlapping. So now already she has got two stents at the layer of the ISR. So with multiple stent layers, I think most of us will agree that we are not very keen to put another stent in this place. So these are cases where actually it is ideal for a DCB where already there are multiple stent layers with under expansion of the stent and now neointimal hypoplasia. So again, like in the previous case, we first pre-dilated with a 3015 non-compliant balloon. Then we took a 3015 OPN NC balloon at 40 atmospheres. And then this time we did the 3015 pearl cutting balloon because now it was available to us. And actually it tracked very beautifully. This is the new balloon from Relicis, which we have used now in a few cases. And it tracks very well because of its hydrophilic nature. And also because it has this smaller blade. So it actually is able to give a good result. So just 1 second, I'll open the door. Sorry for the yeah. So this pearl cutting balloon is a new balloon by Relicis. It is the only cutting balloon which is manufactured in India. And it has certain advantages like this hydrosurf coating, which enhances its deliverability and ability to cross lesion. And also it has this unique folding method with the 6 wings, which reduces the outer diameter of the balloon. And it's a semi-compliant balloon. And the blades are a microscopic blades with a carbon alloy steel. And also there are the deployment markers for the accurate positioning of the balloon. And so we did the cutting balloon and the OPNNC again in this case. And then after this, we did the OCT run. And now we can see that there is a good expansion of the dual layer of the stent. And now we had lumen areas of more than 6.6, 6.5. And this where the double layer of the stent was, it was very well expanded. So with this, then we were confident to put the 3530 DCB for 8 atmospheres at for 45 seconds. And this was the final result. So again, she is now on rosuvastatin with bempedoic acid and insulin for diabetes control. And we are hoping that this doesn't recur. And if we'll check again after 3 months, and if this doesn't recur, we'll proceed with PCI to the LAD. So I think I'll just like to modify my topic today. So treatment of ISR is a complex angioplasty, and there are multiple ways of going about the problem. But I think it's not just cut and coat. It has to be image, understand the mechanism of the ISR. If necessary, expand the under expanded stent with whatever tool you want, then cut the tissue, and then finally coat with the DCB. So I think if we do all these steps, only then we can achieve an optimal result for treatment of ISR with PCI. Thank you very much for the patient hearing. And if there are any questions, then we can discuss them.
Great. Hazra sir, your comments and very, I think, good cases, and you gave the best of the results. Like you can't give better than that. The expansion was good, and ISR, the imaging is the key thing, and that to be OCT preferably. And this is a concern that you're preparing the lesion and there can be dissections, and with contrast forcefully if you're giving for OCTs for checking how the results are, you can worsen the dissections. So this is a concern. So but many studies have been done only with OCT as an imaging in DCB. And for me, it's if I'm doing an OCT after lesion preparation and about to go for a DCB, I like to go for with a saline injection rather than a contrast injection, because contrast can give you more hydraulic injury. So yeah, Prakash, your comments.
Yeah, I think both the cases are very nicely done. Chirag, if I give you a hypothetical case, a 2.5 millimeter RCA, you put a 2.5 millimeter stent, versus 3 millimeter RCA, you have put 2 millimeter stent. And what will be the ISR rate between these two cases? Will be same. The 3 point will have more ISR, 2.5 will have more ISR. What's your guess?
I think the smaller stent will have more ISR, sir. It's more
Okay,
likely.
no, what I said, you have put 2.5 millimeter stent in a 2.5 and 2.5 millimeter in 3 millimeter at 6 months or more at 1 year. Because many situations in CTOs or STEMI, negative remodeling, you may not assess the proper size of the native artery until unless you do the imaging. So in the first case you have mentioned, it was a smaller stent to start with because the operator might not have the imaging luxury. And many of us, my fellows or my colleagues, do not take this imaging catheter because of the cost barriers, and they don't feel it is necessary in all cases. And the penetration of imaging US versus Japan. Japan is almost 100% now. US is around 20% because the US don't get, the operator do not get money, or they are not paid extra fees for the OCT procedure. Whereas in Japan, if you do OCT plus angioplasty, you get paid for two procedures. And second is definitely the adoptions or the confidence of the operator. So my question is again, 2.5 versus 2.5 and 2.5.
Sir, so just to clarify, I'm not saying the index procedure should be image guided, but once the ISR has developed, then I think definitely it should be image guided. And I think it really depends if the 2.5 stent has become 2.5 inside the artery. If it has become 2 in a 2.5 artery, there will be ISR. But if it has become 2.5 in a 3 artery, we may not have the ISR. So expansion is important of the stent.
So if I say the 2.25 artery has become 2.5, a third example, what will be the ISR rate?
No, I'm not able to understand the question, sir.
What I'm saying, that your native artery is 3, you have put 3 by mistake or diffuse atherosclerosis or CTO or not imaging, you put 2.5 and you have inflated at nominal atmosphere. And second patient, you have 2.5, you properly image, then put a 2.5 and nominal atmosphere. Another is 2.25 artery, and you don't have any 2.25 stent. You usually prefer a 2.5 millimeter stent without imaging, we inflated. So what will be the ISR rate on these three
That's what I'm
examples?
saying. The malapposition will not decide the ISR rate. It's the expansion which will decide the ISR rate. So if the whichever stent is the under expanded stent, that is most likely to have the ISR. So I think it may be 2.5 in the 2.5 or 2.5 in 3. It really depends on which stent has expanded well. If the stent has not expanded well, even in a smaller artery, you can get in the bigger artery, you can get the ISR. That's what the malapposition is not related to the outcomes. It's the expansion which is important.
So Dilip, what's your take?
Yeah, so the MSA, which is important. So if you get an MSA of more than 5 in epicardal coronary artery, LAD, mid LAD, and RCA, you are okay. So even if the vessel caliber is 2.5, 3, it is the MSA which decides the future ISR rates and MACE events. And this question answer is very difficult. So 2.5 in a 3 vessel, 2.5 in a 2.5 vessel, which patient is going to have an ISR is very difficult. So, but chances will be higher in 3 vessel. You are putting 2.5, it is under expanded as well as malapposed. So you are
Okay, so I brought this into discussion. The worldwide the ISA rate has not changed. Exactly this 12% over last 21 years in US, 7% in Europe. And still do not know what happens to these fixed rate of ISR. One thing is that we are improving, like if you become senior, you imaging, stent boost, you expand, post dilate, cut and prepare. If you're just fellow, you're scared of post dilatation because it can cause perforations. So the gain you achieved by your experience, you're losing at the same time in the world by lack of experience and imaging. So as a whole, the sum is zero. That means the ISR rate has not changed. So if you really want to change the picture of ISR, the way Chirag has mentioned, many of these ISR has to be redone with proper expansion, cutting balloon, coating them with the best drug. Now that the solution ISR study has been done, if you have two layer of stent, I am sure the DCB will be superior. If you have one layer of stent, which was seen in the solution ISR trial, 80%, I think, two-thirds had just one layer of stent, it will be just non-inferior. Still, you will get few bonanza out of doing DCB because the patient may get a third chance, fourth chance, fifth chance, DAPTs, etc. You can get away with DAPT, you can get away with your imaging. As Dilip was mentioning, some centers may not have any imaging facility. So just assessing your axial fit by a stent boost or a simple balloon, this axial fit and longitudinal fit, you can increase the length of the balloon to accommodate the longitudinal this geographical maze. But the axial fit, you can take a little bit of extra, like 3. If you're thinking 2.75 vessel, you can take 3 because these are subnominal, very low atmospheric pressure. So your painting should be homogeneous. Axially should all the segment get the drug, and longitudinally both ends should also get the drug. I think both the cases taught us this thing. He has done superbly. The first case is beautiful. I mean, the size of the arteries, the flow of TB3 flow. I would say TB5 flow. You got in the first case. Thank you.
Great. So
But
Stalin,
on a lighter note, one who will get ISR is one who is smoking BD and not taking the medicine. So
so Stalin, you can start your presentation.
Yes, sir. Good evening to all. I've been asked to share a couple of cases of cutting balloon and complex anatomy, especially bifurcation lesions. So going right away into the case. So the first patient is a 59-year-old male, non-STEMI, normal LV function. He had calcific LAD and L6 disease. You can see the angiogram. There is a tight osteal disease in the LAD as well as osteoproximal disease in the circumflex. Okay, it's a Medina 111 disease. Distal vessels are quite good. Ideally, CABG candidate, but patient refused, so we had to proceed with a bifurcation PCI. The RC is fairly okay, except for a minor plaque in the ostium. So both the vessels were wired, and we took a small balloon, but the balloon was not opening up, and distal crossing of the balloon was very difficult. It was not tracking distally. So we had to go for a 1.5 rota. So after rota was only done once. I mean, just to cross the lesion, immediately the patient crashed. There was hypotension. There was some ST elevation, slow flow. A lot of drugs were given to tackle the slow flow. Subsequently, once the blood pressure regained, we dilated the ostium of the LAD with a cutting balloon. And subsequently, the circumflex also was prepared with a 3x15 cutting balloon. So this is the image, the intravascular ultrasound after the rota and cutting balloon preparation. You can see that distally the vessel is disease-free. And as we see, we can see, as we come proximally, we can see a mixed fibrocalcific plaque with areas of some amount of lipidic component also there, circumferential calcium, well modified by rota, that is a circumferential 360-degree cut by the rota, a lot of breaks, a lot of modification by the cutting balloon as well as the rota ablation. You can see multiple cuts there. Okay. So we're coming into the left main. Left main is very small, very short, and there is a distal plaque. So subsequently, we proceeded with the DK crush, as we know that is the the technique with the maximum success rate as well as the long-term outcome data. So long stent was placed for the circumflex, which was crushed with a 3.5 balloon in the LAD. Subsequently, recross and initial kissing was done. Even though the LAD appears to be stented, actually there is no stent. That is a calcium which is visible as almost like a stent-like tram track layer. And subsequently, LM-LAD stent was placed and followed by a pot. And this is the this is the post IVUS. You can see that the circumflex is well open. We're coming to the ostium. Generally, we have the Kang's criteria, that is a 6, 7, 8, and we have the newer Excel data and the Noble trial data all suggest that we have to achieve a area of at least 6 in the circumflex. We are able to achieve only 5.88 despite all this cutting balloon and other high pressure dilatations. And this is the LAD. LAD, the areas were quite good. We were able to get area of 7 in the proximal LAD. In the osteoproximal LAD, 7.9, that is very good. And the distal LM also was quite good at 11. And so we were able to achieve the Excel criteria, except for the ostial circumflex. Okay. And these are the final results. So despite the vessel being heavily calcific, we got an excellent angiographic as well as imaging result because of the multiple modalities, that is the rotablation with the cutting balloon, that is the rotacut technique, especially, which is very useful for osteal lesions and bifurcation, because we know that the ostium is extremely fibrous. Along with the calcium, most of the time it will be a fibrocalcific lesion in the ostium, which is unyielding to a normal traditional NC balloons. So cutting balloon, what it will do is it will cut the tough fibrous part, thereby allowing the stents to expand and get a good ostial areas in the bifurcations. So coming to the second case, this is a slightly more complex patient. It's a 64-year-old male, non-STEMI, EF of 35%, history of inferior MI in 2003. That time he had a single vessel disease, CTO, which was managed medically. And now he presented with exertional angina and class 3 symptoms. So that was the angiogram. We can see that there is a CT of the RCA. We did the viability study that showed that the RCA territory is non-viable. So he was taken up for the PCI as he refused CABG. And this is imaging findings of the LAD. We can see that there is 360-degree calcium. We can see that there is a tight nodular calcium at the ostium of the LAD. And there are a couple of nodules sitting in the opposite walls of the LMCA, creating almost like a slit-like space in the LMCA. So this is a complex case. We need multiple modalities. So initially we took the IVL because we know that there is a lot of calcium sitting in the left main, and we took a 3-5 IVL. But unfortunately, after 6 pulses, the IVL balloon ruptured, and subsequently we were not able to take the second IVL balloon because of cost constraints. So the next best strategy would be to top it up with the high pressure balloons as well as the cutting balloons. So after high pressure balloon preparation, the routine strategy, we did the crush technique here. This is the mini crush, not the DK crush. And L6 was stented with the help of a guide extension catheter. And subsequently the stent was crushed and a long stent from LM-LAD. And the final steps were like kissing balloon inflation, repot. After that, there was a strange image. I mean, we can see that there is a, in the stent boost image, we can see that there is a discontinuity of the stent in the distal limb because of the high pressure opium balloon dilatations. So you can see that in the IVUS also, there is a stent fracture in the LM because of the nodular calcium. Even though the lumen area is quite good, we were able to get a lumen of more than 11. There is no continuity of the stent in the shaft of the LMCA. So we cannot leave that like that. So we had to place another short 4 into 8 millimeter stent. And then subsequently a pot was done at with a 5O balloon at very high pressures, up to 26 atmospheres. Okay. And this is the final IVUS run. We can see that this still area was 6.3 in the LAD as at the tightest portion in the distal part was 5.6, which is still above the cutoff of 5.5. Ostium was very good at 9.5, and the LMC or MSC also was quite good at 12.37. So we were able to satisfy the Excel criteria, right? So these are two case examples where the cutting balloon in combination with other modalities really made the difference. So any questions regarding the case?
Excellent cases, Stalin, and what we see is circumflex ostium. I think which this particular position is discussed more often now because of its complexity and future recurrence of the problem there. And DCB is coming in a very good manner. So we also have done so many cases of left main circumflex ostial DCB with cut and then provisional stenting to the LAD. And this LMCA to LAD, it gives really good results. And cutting balloon, when we are at left main bifurcation, we are going for rotablation. The only problem is you don't have wire in the side branch. But if you want desperately a wire there, so how can we achieve this kind of procedure? To keep a wire in the circumflex as well as do a rota in the main branch?
Yeah.
Can
So
you highlight there?
yes, sir. So I have experience with that, sir. We had nasty dissections in the circumflex, especially after rotablation to the circumflex, and we want to do the rotablation of the LED. What we generally do is we keep a microcatheter. We don't keep a wire. Microcatheter has this lubricity, especially a Newark microcatheter, the fine cross. If we keep it quite distally, that is quite safe. It does not get damaged with the rotablation of the LED. But again, for that we should have at least a 7 French guide. If it is six French guide, definitely I've tried. We got stuck with the microcatheter. We had to remove everything, rewire. All those problems can occur if the guide size is not adequate. And also, if you use a reused microcatheter, again there'll be a significant problems, friction while taking the rotablation.
Absolutely. So you can have either a 7 French or a ping pong catheter guiding catheter. So two guiding catheters. Through one guiding catheter, you take wire, and then microcatheter in the circumflex. Through other, you do your seamlessly your rota and all. So with that, you can have a protection, or maybe a 7 French guiding catheter, or even bigger with a side branch and then a microcatheter there. So rota is very very helpful there, and with the IBLs where you need can keep a wire there, side branch and do a calcium modification. That is also now people are preferring. So Prakash, your comments and
Yeah, both the cases nicely done, executed very nicely. Imaging the recent criteria of left main PCI trifurcations, not 5, 6, 7, 8 anymore. It is 7, 9, 11.8. So you have done perfectly. Now I have also used yesterday two cutting balloon from Relicis. These are very good balloons, easily trackable on ISR. So my first question to you regarding the rota, as Dilip has mentioned, if you do rota of any artery, would you be wouldn't you be very careful using a cutting balloon after, orbital or rota in a segment? You can use opium balloon fine, but if you use a cutting balloon, there is always a chance of perforations. So do you think it is an appropriate decision or from your side, or it was a necessity of the day?
Yes, a very good question, sir. So there are trials. The Rotacrat trial, as you know, by Dr. Shamin Sharma, has shown that the rota followed by a cutting balloon strategy is very good in terms of reducing the amount of dissections, the amount of complications. And in our center, rota is almost daily routine job for us, because most of the cases are referred cases where we get the highly complex calcified lesions, CBG turndown cases, where one modality will not work. So almost like 80% of the cases, we need either a cutting balloon following the rotablation, or an IVL, or an OPN balloon. But among these three, we found out that the IVL is the best when combined with the rota, that is the rotatripsy. Second comes the cutting balloon, and third comes the OPNNC. I've had a couple of cases where the proximal LED has ruptured, frankly ruptured, after doing an OPN following a 1.75 burr. So I'm quite worried about doing the very high pressure dilatations following the rotablation. But with respect to cutting balloon, we don't have to go at very high pressures. We can just stop at 10, 12 atmospheres and get away with a very good results. That is the advantage. And the most important thing is that we should not oversize and avoid cutting balloons in bends. If there is an acute 90-degree bend, we should not take the cutting balloon and inflate at high pressures. There, the chance of perforation is quite high. That is my personal experience, sir.
Right, there is a trial in TCT this year, OPN versus cutting balloon, but cutting balloon is much cheaper now than your OPN balloon. That could be one of the reason. And second, you have to be very careful going to 24 atmospheric pressure. Like without rota, you can go to 24 atmosphere. But if you're doing after rota, never ever try to go to 24 atmosphere. Be gentle around 12, 14. That is the nominal pressure mentioned in that cutting balloon. And you have done so, accurately. And you have also said that it should not be high pressure anymore after rota. Before rota, you can do this jugularly. But after rota, orbital or laser or IVL, you should not use very high pressure and that too more than 0.7 ratio of the artery. So be on the lower side of pressure, also the lower size of the sizing of the cutting balloon. OPN again, as I said, as you have mentioned, the OPN usually there is a tendency that it do not expand. OPN also expands to small extent, not to the extent of compliant balloon or non-compliant balloon. It does gets expanded when you actually inflate this OPN balloon again and again. The first inflation may be up to the ID, up to the technological markings they have mentioned on the balloon. But if you keep on inflating this OPN balloon, also the same OPN balloon can get bigger and bigger by at least 8 to 10%. So rather than going to 35, 40 atmospheric pressure, you should assess this artery again by imaging why your rota has not worked, whether rota higher speed or higher size, changing the wire from your floppy to extra floppy, whether is a rota wire bias at the angles, at the ostia. There are so many things can be done, but a hybrid therapy is almost always required in 30% of calcified lesion. Trial after trial has shown that, whether it is roller coaster trial, any other, those who are dealing with really heavy calcium, especially second case, on non-doable case, definitely you have to use the second disease calcification modification agent. Now, I think this will be last question. If you have a patient who has got a graft failure and a stent failure, for example, LED, which one will try for? Whether you will go for a graft or you will go for a stent failure? Is there any data? Is there any strategy? Is there any change in the mindset?
Yes, we have a trial recently published in is recently presented in the TCT that shows that it's a randomized trial that shows that the graft PCI is yeah,
Proctor.
is safer compared to the native vessel PCI with a durable outcome. It's not like superior; it's almost equal outcome, but much more safer during the index procedure. That's what the data tells us.
My question is
So
different. In the Proctor trial, if you have a CTO of the RCA versus graft failure to the RCA, they have gone for, previously you used to do CTO of the RCA. Now they are saying better to go for a graft PCI rather than, so it's a myth breaker. So my question is, you have a graft failure and a stent failure. And usually stent failure in long term usually CTO. So what do you do? I think your answer, you have already answered that you should go for a graft again.
yes,
Because
sir.
stent failure in long term, chronic total occlusion due to stent, almost undoable case. And what's your take, Dilip? Graft versus native?
Yeah, so I think Proctor is a very out of league trial, and the results which the long notion we had and lot conviction we had to open the native vessel, native will be a durable, solution. They have kind of questioned, and but only one trial is not going to change our habit and kind of conviction. So I still will go after native vessel, and provided the native vessel is totally, diffuse disease and you can't do it's non-doable, only in that situation I will try
So
graft.
just because one trial, you're not going to change your practice. If I give you a trial of STEMI and thrombosuction showed increased stroke, and just because of one trial, they put it in class 3, it's test trial, just because there is increased incidence of stroke. One trial, the thrombosuction is a contraindications in class 3 indications. If one trial put the data into negative zone, why can't one trial with positive data put in the positive zone?
But here there are a lot of variables there was a very clear idea that routine thrombosuction was not required. So still we are doing thrombosuction in patients where there is a large vessel, 4 vessel totally cut off. We still go for that. We still feel there's a large chunk of thrombus. We still do thrombosuction. So that was a different scenario. And here also there are too many variables are there. How big is the graft? How young is the graft? How is the native vessel? How badly calcified diffuse disease is the native vessel? Whether the CTO is doable or not, whether at all it is a CTO or not. So many variables are there. So one trial like a Proctor will not give a kind of a idea. So it depends on patient and patient. That's what is happening in thrombosuction area also.
Right.
We have 2-3 points here what we were discussing. OPN we are using. OPN also after 35 atmosphere pressure, it becomes unpredictable. So we have to be careful when we are going beyond 35 with OPNs also. And number two, I will be scared that, in 1:1 cutting balloon after rota. So if I am not happy with rota result with 1.5, I would be, happy to take 1.75 rota to make it more, good, and then after going after with an NC balloon rather than a cutting balloon. So after rota or orbital, where I still feel it is not a good job, I can increase the speed with orbital, reduce the speed with orbital, reduce the kind of your movement with your orbital, which gives a bigger cut, and I can go after with a larger rotable, burr. And I would trade with a better with a NC balloon going high pressure than a cutting balloon in these situations. And if we are taking cutting balloon, it has to be 0.75, not 1:1. So these are my
Right.
takes. Yeah.
Chirag, you have any counter comment?
No, sir, nothing. Thank you.
Why not?
But I'm still, again, I'm not so convinced about stenting the vein grafts. Because old 20-25-year-old completely degenerated vein grafts, I'm not so sure if it's better to open the native, especially if it's not a CTO. If it's a CTO, again, it's a different story. But if it's not a CTO, if it's just a doable angioplasty of native, I'm not sold on that. Just doing the vein graft. Actually, we had that problem just few days back. She had 3 vein grafts, LAD, OM, and RCA. And the vein graft to OM was showing a 90% stenosis. And she had another 90% stenosis in the proximal circumflex also. And very doable angioplasties. Both are not very complex angioplasties. So then this is the real situation where we are not sure. But because of the trial, I have stented the vein graft. Now let's see what happens.
No, I think one trial and that a lot of variables are there. How
Yeah,
if
I
you have
think
a good
what
native
Dilip
vessel with a doable angioplasty, you should be going after native.
I
Yes.
think what Dilip has mentioned is very important here. That not one trial cannot teach us each and every point of your learning and your treating a patients exactly the trial way. Like there are a lot of variables. Now, if you think this patient will do better on native, let's go for. Now, if this trial, the same trial, Proctor trial, the CBG, sorry, bypass graft arm versus your native arm, there must be some patient because of the trial, because of the bias and blinding, some patient who are actually a easy peasy case, like 90% circumflex, and unfortunately that chap was in vein graft arm, he got a stent there. So those kind of things can happen, but in usual practice, as Dilip has mentioned, take your own call, and if you are confident of opening that native artery safely, effectively, with less contrast, and without producing any complication, let's go ahead with your, this native. Now, Stalin, I think I'll ask you one question, one last question.
Yes,
If you
sir.
have a vein graft and Chirag has mentioned 90% circumflex he has opened in a jiffy, would you kill that graft or would you preserve the graft?
So I'm an old school guy. I used to I used to coil the grafts if it is reasonably flowing, like if it is less than 70%. But if it is already critically stenosis, the flow is slow, I just don't
So
usually
how do you kill the graft? Tell us.
coiling, sir. I just take a
Coil will migrate, no? Coil will migrate, get
No.
recolonized. What is the latest technique of killing the graft?
Latest technique.
Yes.
I'm not aware of that, sir, but I generally.
So what you do,
generally
you
coil
can
it.
put a stent, suppose 4 mm graft, you take a long stent, you inflate it around subatmospheric pressure in the first inflations, then you withdraw the balloon 50%, then you go at 12 atmosphere, 14 atmosphere. So what it becomes a flower, like flower vase shaped, no? The distal becomes 3.5 and proximal become 4.5, for example, and the proximal is larger, so that will hold the stent, and the graft may not slip through the stent because it is now gets entangled. But if you do not put any stent in the graft, just the coil migrates, the graft gets recanalized, and this coil goes into the native artery. It can migrate anyway. So these are the new things we have learned from today's speakers. Excellent discussion, excellent cases, brilliant demonstration of the skill, the knowledge, and the depth of doing cases confidently. But one thing I tell you, the first speaker has killed your beautiful time. So next time, the first speaker has disappeared, I think, and you should restrict your talk to stipulated time so that you respect others' presentation. That's my last. Don't take it serious. Don't take it to your heart. But others are also precious. Every presentation is precious. So if you kill 40 minutes in first presentation, the others do not get any chance to showcase their talents. Thank you.
Thank you, sir. Good night.
Thank you,
sir.
everyone. And Madhumita, over to you. Thank you so much.
Yeah, so thank you very much. On behalf of Relisys, I want to extend our sincere thanks to all the faculties and the audience who have joined us today evening. We hope that this webinar could be able to bring an insightful discussion on the table, and we will continue to do this academic webinar series, and the next date will be 6th of December. With this, let me conclude the session here. Once again, thank you very much. Good night and happy weekend. Thank you.